All right, everybody, we're going to get started. So welcome everyone to our group discussion component of our summit today. All right, so welcome back, everybody. We're very excited for this afternoon to engage you guys in discussion. We've been talking a lot. You've seen some of the research, you've seen some of the initiatives, but now we kind of want to hear from you. So we're going to be doing some polling questions. So you can use this QR code, and I'm just going to open it online. And I see we already have people answering, which is fantastic. So the way that we're going to be leading this discussion, some of the questions we're going to kind of start with a polling question just to kind of get the feedback both from those of you in the room, but also those of you online. So we want to know, which practice guidelines do your policies and procedures stem from? So we have several different options here, and we've talked about some of these best practice guidelines already today. So we have the International Prevention and Treatment of Pressure Injuries and Ulcers. We have the RNAO best practice guidelines, so the assessment and management of pressure injuries for the interprofessional team. For now, title changing. We also have the Wounds Canada best practice recommendations, as well as the Canadian best practice guidelines for the prevention and management of pressure ulcers in people with spinal cords. Other is also an option. I would love to hear what other guidelines you're using, perhaps the infection management ones. If you don't have any policies and procedures, let us know. And for those of you currently working on this, I see 7 right now. Fantastic. So let's start talking here.
So a lot of our attendees actually selected the RNAO assessment and implementation of pressure injuries for the interprofessional team. And for those of you who answered this question, I just want to know, we actually want to know, what made your organization select this type of guideline for your facility? And I'll be walking around. I may have to volunteer some people to provide some feedback. Any takers? Or we can just ask a general question, why they have selected a particular guideline in their organization.
Hands up if you're using multiple guidelines in your policies and procedures. I'm actually surprised that there isn't more hands up. I feel like I'm always cross-referencing. Let's hear about over here.
No,
Yeah, no, I want to hear from you.
actually, we use the RNAO best practice guideline, also the NEPA one, because we have Baker has affiliation with RNAO, and we always follow the best practice guideline at our workplace. And I had the ACPF from RNAO on pressure injury. They really have good on. They have 2 policy best practice on assessment and prevention, and also identification and risk assessment. They're really good. So yeah, we're following that.
That's fantastic.
Yes.
Okay. So they are a BPSO, or best practice spotlight organization, that allowed them to implement all these important best practices as part of the trajectory of being a best spotlight organization credentialed. Are there any other best practice spotlight organization in the room?
We are also a best practice spotlight organization, and it's helpful because they help with the funding for people who come, for people who go through the BPSO program, and then help on a more unit level provide guidelines. And not just for pressure injuries, but for like falls, central line infections, a bunch of different things.
Fantastic, thank you. So for those of you who are using multiple guidelines, I'd like to know, is there something from a specific guideline that you like to see? Or is there some reason why you're using a combination? And that might be a hard question.
You can also pass it to your colleagues.
I would say that everybody is probably using all of them, or more than. There's such a huge amount of overlap between them. We're all there's some, like, you know, some specific things to different guidelines, but there's also a lot of overlap between them all. So I think even if you don't think you're using them all, you might be.
Are there specific guidelines that you have selected to implement, or or are you like implementing all of the guidelines that have been presented, or which ones do you kind of like select as part of your implementation?
I think it depends on your facility. Because I work in a post-acute setting, I have access to OTs, I have access to PTs, I have access to the dietitian. I think when you're working in the community, it might be a little bit more difficult to like integrate those people into your policies. But because I am in a well-resourced facility, whatever we like can access, we mostly do.
How about others? Is there one favorite guideline that you've implemented or several guidelines that you chose to implement based on your current setting and the resources available? You want to be part of the program?
I think an important part of the guidelines as well is things that nurses can do without being told, that they can do within their own scope at the bedside. So things like turning Q2 hours, changing the incontinence brief as frequently as possible, getting allied health involved, things that they don't necessarily need a doctor's order or permission to do, something that they can initiate quickly by themselves.
Thanks so much. Now, with regards to your organization's policies and procedures, do you have methods in place to maintain the sustainability of the policies and procedures and making sure they're kind of up to date? I see some nodding. Do you want to speak to that?
Yeah, so I was just saying to Tracy, we've updated our pressure injury guideline 3 times in the last 10 years. We've been doing a lot with dark skin tone skin assessments and use of technologies, and we've actually made pressure injury prevention one of our 5 kind of key priorities for the corporation. So we've really been putting a lot of focus. Like we just spent 1.8 million on beds in this last fiscal year. So we're really having a big pressure injury push. One thing that I would say that is really lacking in all of the guidelines is neonatal and pediatric. It's like dead silence for them. So for those populations, we have to be very creative. There are no low air loss available in Canada for a neonate. People end up using the Z-Flow, which is not a mattress, but that's what they end up using because there is nothing else that exists. So there's definitely a disparity for certain patient populations that does not get brought up on a regular basis. But that's something that we're doing in Hamilton. There's been a really big focus, and I think a lot of that came from it being classified as a never event. I think that was something that finally got their attention when they're submitting X number per month to the Ministry of Health. They're like, oh shoot, we've got to work on that, and that's where I think some of the focus came from.
I think it's so hard with those at-risk populations just because the research really isn't there. And I think a lot of the times that's where we have that disconnect. We know we want the guidelines that are based off of the most up-to-date evidence we have. But for these populations where there isn't good research, how are we supposed to innovate? How are we supposed to make leaps and bounds in the prevention of pressure injuries for them too? Lovely. Josh.
I'm just going to go back to the first question that you asked. I wanted to recognize the tremendous work from the Moves Canada guidelines. Within Baycrest, we implement or we use rather the Move It, Move On guidelines, and that's certainly changed the way that we view mobility. Just thought I would share that with everyone.
Now, a follow-up question to that is that when you are selecting guidelines, can somebody comment about the journey that it takes for you to implement and adopt a guideline? Is it a straightforward guideline that will happen overnight? Or is it something that takes months or years on end? Would like to hear more from that.
I can add a little more to that. I think that it really does take strong leadership within your community. And so we were quite fortunate to have our chief nurse executive, who happens to be here, but I won't embarrass her, along with our directors and manager group, manager teams, as well as our advanced practice leaders. I think it takes a really strong group to buy in and also mobilize, meaning working together within a working group to discuss how could we make a square peg fit in a round hole. And so that takes months of conversation. And then it also takes months of socialization as well, being present on the unit and huddling with your teams. We don't have it down to a perfect science, but I did want to just recognize that there is stuff that's out there, and tapping into other community partners, I think, is also very important because, you know, we don't want to work in silos. We actually want to work together, and we all have that intention to work together. So let's, you know, break down those barriers and have the conversation as a community. Oh, and a special shout out to our champions. We have pressure injury champions within our organization, and they are the cornerstone of really putting together. They are out in the front lines, and they are the ones that are implementing most of these strategies and coming back to the table and sharing with us how we can even improve on those strategies. And also RNAO ACPF, we have our ACPF here, but also capitalizing on that initiative also supports some of these great strategies.
I love that you guys are all using, you know, a variety of resources and kind of tailoring them to your environments, but also capitalizing on the resources available. You know, we've heard RNAO resources as well as Wounds Canada. Really fantastic to see that we're using the resources that are at our hands. So I'm going to just kind of go forward to our next. If there's anything else you want to mention, Josh?
Not right now.
Okay. All right, so this is a bit of a big question, and you can select multiple here. But how are pressure injury risk being assessed and documented in your setting? So I know we've talked today already about different types of documentation. We talked a little bit about some organizations using paper versus electronic and how data collection is a little bit easier or quite a bit easier when you have electronic documentation. So we really just wanted to get an idea of where you are at in terms of both your type of charting, but also what are you using to assess patients who are at risk of pressure injuries? Because we know there are a lot of resources out there. So some of the more common ones that we're seeing are Braden, Scale QD, Norton, Waterloo, PERS, which is also integrated into RAI. So sometimes you might be using that and not actually realizing, but it's all integrated together. But yeah, so we see a lot here are using the Braden scale, which is quite a user-friendly scale. So that's fantastic. Now, from those of you in the room, how many of you would say that you use a validated tool, but then also are putting your clinical judgment on top of that to decide what you're going to be doing for these patients? Yeah, and that's kind of what we've seen across the board is, you know, the tools are just kind of one piece when we're trying to determine clients who are at risk of pressure injuries, because we know that a client can be at risk today and they could have a pretty good Braden score, but their risk might be lower because they have such excellent care right now. So it's all about kind of putting perspective on that. If that care were to stop, where would they be? It might not be good. Josh?
The other thing I want to ask, Ashley, there is 4 individuals in the room or somewhere who answered other. And not to put anybody in the spot, but I would like to know about what is being used in your site in assessing someone's risk for pressure injury. If anybody can speak to that.
Used for the pre-op patients, it's the Monroe scale.
Of
That's
course,
the
yeah.
other, yeah. And I don't remember the name of the neonatal one. It's Lunderst.
Yeah, what is that scale?
Oh, Don't put me on the spot. I'm not very familiar with the scale itself, but the Monroe scale, because when we were looking at pre-op patients, the Braden was not fitting the population, right? So they looked at different scales, and Monroe scale was one of the ones. And then they took permission from the person who has designed it, and they've modified it for our pre-op population. So it goes from the time of preoperative admission, intraoperative and post-operative care. So at the PACU level, it is removed, and then they switch to Braden if they get admitted. If they are discharged from same-day surgery, then the scale ends right there.
Thank you so much for that, Sneha.
I think, Sukainda, that's a very good point because not one single validated tool I find in practice can satisfy all the different types of risks and contributing factors out there for patients. And sometimes when you even look at, for example, the Braden scale, somebody may score moderate risk, but if you look at their whole entirety and they may have comorbidities that predisposes them from, increasing their potential to develop a pressure injury, they may actually definitely score even higher than the score that was based on the Braden scale. Now, in terms of risk assessment and care planning, how many in the group here that after you have done a risk assessment, how often do you continue to do your risk assessments in your settings?
Risk assessment every shift. We have to do it every shift. Yes. Chronic cases, chronic complex cases. Yes.
You see here, we do on admission, change of health status weekly, and readmission. So if someone goes into acute care and comes back, we have to do our Braden again.
So we see every shift over here. We see weekly admission, change of status, and readmission. Yes. Fantastic. Anybody doing any scales more frequently than that or less frequently? I'd love to hear. Yeah, over here, we have a couple, Josh.
Hi, so I'm a quality lead for pressure injury at my workplace. And just in terms of overall at the community hospital, on our medicine units, I think we do it every 24 hours. But in areas where we have a bit more prevalence, like critical care, over there, they do it every shift. So.
Thank you so much.
A follow-up question before heading. Okay, go ahead, Carol, before I make a question.
Yeah. Oh, okay. Because for spinal cord program, again, we mentioned and we've seen it in various presentations that the spinal cord injury patients are at high risk. So therefore, our frequency for the Braden is on admission, change in status, and on readmission. So that's less frequent than most people.
And I wonder, as you are doing your risk assessment and the frequency of your assessments, do you find any variance or changes and differences in the results? Anyone?
I could answer from my perspective. So I work with a long-term patient stay population. So we're in complex continuing care. And often we're finding we're doing weekly in our environment. And often we aren't seeing changes. Or if we are seeing a change in score, it's sometimes based off of clinician interpretation. So for example, from the nutrition perspective, are they well nourished or not? I have a lot of nurses questioning, what should I choose if they're enterally fed or if they're part enterally fed and part orally fed? So a lot of these scales, there is some interpretation. Sometimes you can have changes in numbers from that, but yeah, I find overall with a more stable population, you might not get the changes, but when you have a more sick population or a more complex population, then you can have more variance assessment to assessment.
Now, Kalim, let's head into the virtual world and see our virtual attendees. I think they have a couple of comments there too, and questions. So one of the comments that was made here is for continuous complex care patient who will likely have the same high to mid risk level for the rest of their stay at the unit, what is your recommendations for how often the risk assessment should be repeated?
That's a good question. And I feel like from my perspective, there's no actual right answer, right? I think a lot of it takes into account PDSA cycles within your organization. I think we've seen quite a variance in the frequency of assessments, but if you're seeing that all of a sudden you're seeing more pressure injuries on your unit, or perhaps you're seeing pressure injuries and the clinicians aren't sure why this patient got a pressure injury. They didn't have one last week, they were doing fine, and now all of a sudden they have one, then it's maybe time to rethink. Maybe we should be doing a blitz of doing this more frequently, to see if we're missing anything, because that's really why we do these assessments. It's really to reevaluate, is there a change in status? Is this patient at more risk of acquiring a pressure injury? That's what we are doing these for, is to not lose our patients, but also if we are seeing changes in their risk status, what are we doing to put things into action to prevent a pressure injury from occurring, right? At the end of the day, any risk tool that we're doing, it's to inform our practice and our interventions. It's not to be done kind of by itself. It's always part of a care plan.
I find that for satisfying process indicator pieces for quality initiatives within the organization, it's good to do it on a routine, frequent basis. But in the context of knowing your patient, it is actually good to do frequency based on the level of risk or the significant changes that a patient may present. Like somebody who may be more mobile today, for example, who had a fall the next day, they may be requiring a bit more frequent reassessments thereafter because of a change in status. So I think as we get to know our patients, it's important for us to really understand what are the risks and contributing factors that we were looking for, and knowing holistically what are the other associated comorbidities that may be present that are not part of your risk assessment that may then justify the need for a more frequent approach in reassessing a patient. Any other comment from the group? Yep.
I just wanted to emphasize the point Carol made about, particularly in a spinal cord population where people are already at such high risk, repeating the Braden so frequently may not pick up some of the other contributing factors. And you were talking about comorbidities, but sometimes it's not necessarily comorbidity, but it's a patient who, what I was talking about before, a patient who is becoming more independent. So they don't have someone laying eyes on them all the time, which puts them at greater risk for that. So I think it's also, and I think our nurses do that every day here, it's recognizing all of the other contributing factors beyond what's in the Braden. Patient's mood is low for that day, so they might not be turning as much and things like that. So I think it's recognizing the Braden as one tool, but it's also everybody's clinical assessment and clinical judgment of that patient each day, and recognizing there's not going to be a risk assessment that'll pick up all of those factors.
And I like that you mentioned that, because the thing is, sometimes when people are developing preventative plans of care, they're so focused on the score of the actual assessment as opposed to the signified various factors that are present. Like, for example, will you actually develop like a moisture management plan for somebody who is always dry? So we can't really just justify the score itself, but focusing on the segmented types of contributing factors within the assessment that makes the preventative plan a bit more individualized. There was a comment here.
I'll just start here. So one of the things I wanted to mention, whenever we do our pressure ulcer prevalence audit, we actually find the people who develop pressure injuries do not score with a high Braden or low Braden, right? They're not high risk. The nurses can identify long before the person does the Braden that they're high risk as they're being brought down the hallway. And I find people then very aggressively put in the interventions. When they're marking that low or moderate risk, those are the people who are the most vulnerable or the most at risk actually for developing pressure injuries. Because again, those comorbidities, they're refusing to turn. We make assumptions, well, they're more mobile. So we don't need to monitor as carefully or be as aggressive with our interventions. But that's what our finding has been, that the high risk, we're very good at, and they're not the ones who tend to develop it.
So I am placed in an acute setting, and if I can echo and speak to preventable measures, I think it's it's super important once you have the knowledge, you're obliged to share the knowledge. So patient advocacy and also patient teaching, like just because you're doing, letting them know what you're going to do and have them, give them the opportunity to participate, actively participate in the care will make a tremendous difference, because then as we as nurses, we would like to be perfect, but we're not. We're human as well. So there's room for error. But if you are going to share that responsibility with your patient, and while you're doing the skin assessment, letting them actually know why you're doing it and that they may be at risk. Therefore, you will empower them wanting to get up, be more mobile, agree to maybe better hygiene. Those are like those little contributing factors that if you can address them at the beginning, you can avoid a lot of trouble later. So I think it's worth talking about patient advocacy and patient teaching, like actually spend the time. We do check off, like I know when I do my assessment, health teaching, and sometimes you catch yourself and others just checking off those boxes, but I know the conversation didn't take place, right? So I think it's very important to actually focus on patient teaching as well, having that conversation.
I think that's really important, Margarita. And I think even kind of expanding on that, the family and the caregiver teaching as well, as we heard from Dr. Gabison today. I always say, you know, when families are there, so often we want our patients to have all their care and all their things done so that when the families are there, they can just have a nice visit. But especially for our patients at risk of pressure injuries, it can be very educational and really worth the while to do some of that care while they're there so that you can show them what you're doing, what you're checking for, showing them how to, you know, position, reposition patients, and how you're assessing for their risk of pressure injury. Sometimes we'll say to a client, oh, you're at risk of pressure injuries. What does that mean? How are you deciding that? So I think it's really important that we're really engaging the clients and their circle of care in those discussions and teachings.
Yep. So Kaylin, there's a question on the chat. It says, is there any strategies notice that is helpful to help staff think beyond the risk scores, but moving to prevention and intervention? The 2 cents I can give to that is sometimes it's a lot easier to try to push for change because it is selected, adopted implementation guidelines you want. But I think it's about the culture of shared accountability. Like if we focus a culture that actually focuses on prevention and management and try to understand where are the gaps that allows them to buy into that change, that's a better strategy to do. It allows you to streamline your change approach process that makes it a little bit more effective. Do you have anything to add to that, Kaylin?
No, I think that's perfect, Josh. Thanks.
Any other comments? Yeah.
I know Linda had mentioned this at Wounds Canada, and I started looking it up and being really intrigued by the Purpose T tool that's in Europe that is basically a replacement of Braden, but ties in the interventions to the risk assessment and writes it out a whole lot better. So to speak to that same question is looking, at other options out there.
Like that.
So yes, it's Purpose T out of Europe.
So I joined Sunnybrook in 2018, but the my predecessor had actually taken permission from and modified the Braden score. So our Braden score has the whole scoring on one side, and the second page actually gives you all the interventions you can do with it.
That's fantastic.
So it has been already, like you can sort of get permission and modify it.
I just wanted to build on the comment that Joshua made there in terms of getting buy-in through awareness and teaching. And I just was reflecting on, I think Chester made some great points earlier in his talk about carrot, stick. I think there's a third option, which is like the carrot and the stick are both, to me, kind of external motivations. Culture change, what Joshua just touched on, I think is internal motive. What we're saying is as a team, we're going to try to be whatever, our organization's going to try to be the best in the world at this or whatever. We don't want any patients ever to have to suffer with this problem. I think that's an alternative that will take, first of all, awareness, teaching, training, all of that stuff, and everyone working together. So that's, I think that's, yeah, I think we probably also need some carrots and sticks in there as well. But yeah, that's great.
It might be the hybrid of both. And I think one of the simplest message that we can have is no matter what score an individual may have, a risk is a risk. So at the end of the day, they can be severe tomorrow, they can be moderate, few weeks later, but it's about acting as soon as possible. And the message that was given out by Dr. Craven earlier is that as soon as we know that there is identified risk that a patient may develop a pressure injury, like for example, coming into an ED with the fear of getting a pressure injury, then probably we need to really act there and immediately there and before anything else could be worsened over time. And I've seen also one of my clients that was recent, but probably a year ago, who was perfect skin. They have a risk of about probably 14 on a moderate Braden scale risk, but is considered a CCC client. Now, the patient never developed any pressure injury while they were at the care of the nurses on the complex continuing care, but it only took possibly about 24 hours that they developed a suspected deep tissue pressure injury that then evolved into an unstable pressure injury and then transitioned into a stage 4. And that process then prolonged to about 6 to 8 months before it fully closed. Why do we have to subject patients and their family and their caregivers to that kind of trauma if we can stop it immediately, not knowing that, the cost that we are trying to minimize by buying all these preventative strategies ahead of time is actually a lot cost saver than treating a pressure injury?
Absolutely. Those culture changes are so important. And we talked about surfaces today and about how we need to get clients on the right surfaces. But what if all of the surfaces in your facility had the ability to prevent pressure injuries? Of course, you might still have more different surfaces for different reasons, but something as simple as the baseline care that you're providing being preventative care can make a huge difference. I'm just going to move on to our next question here. Love the discussion. But I want to know, how are pressure injuries documented in your setting? So again, I'm asking about type of charting, but also I just want to know where they live. And this talks a lot about the data that we've been talking about today, because we do see that pressure injuries can live in different places, in different systems. And we really want to just kind of get a better idea of where are we finding. A lot of responses coming in, fantastic. So we're seeing a lot of respondents talking about the admission and initial assessments, which is fantastic because we want to make sure that we're, when we're intaking patients, that we're getting that information. And I hope those same people are also responding in the other categories, that they're continuing to document on those pressure injuries. In terms of people who use multiple areas in their charting systems to document pressure injuries, can anybody talk to the ease of information finding from a clinician perspective?
Please do.
It's not easy at all. And that's part of the main issue, is that it's very challenging to find that one spot to go to get the most accurate information. So the source of truth, essentially. So a lot of our sustainability activities right now is really focusing in on the documentation. Because if we want to be able to evaluate our successes, we're going to need that source of truth.
Have you found anything that works for you guys?
I'd say not yet, but I think the first step is frequent auditing. We're taking a look at. So in the absence of having an electronic push type of reporting system, they are essentially manual audits. But from there, we're hoping that we'll find, the areas where we do need to standardize our documentation.
That's fantastic. Yeah, no, I think the auditing is always the first step in seeing, what's being done and then kind of growing from there. Carol?
Hi, I don't know if your documentation is a chart-based paper? Is hybrid? Okay. So we do have electronic documentation, and I find that it's easy to find the information, especially when you go under the summary tab. It actually comes up as a nice summary, and to the right, those of us who uses Epic, it's actually summarized right there, the type of pressure injury the patient has. There's also an avatar that we have, just a replica image of a human being, where the wound is also documented on. And then to highlight, we also have a wound dashboard where you could actually go into and slice and dice and actually find the unit that has that particular pressure injury, or how many pressure injuries are on a particular unit, the type, and so forth and so on. So maybe because it's electronic, it's easier to find.
That sounds dreamy.
Hi, I'm Melanie, clinical nurse specialist at Rehab Providence. It's very challenging for us right now just because we still work on a paper chart kind of pathway, but in the next couple of weeks, we are transitioning to Epic, so I'm really looking forward to working with Epic. And so it's very fragmented in being on a consultation basis of finding the truth to what you're trying to look for. And so a lot of my digging is coming from Connecting Ontario, which is the truth of like kind of where the wound started and so forth. And so it is challenging, but we eventually get to the main point and treatment plan of what will work for our patients. But I'm really, really looking forward to Epic. My training is tomorrow, so cross fingers.
Hi, I'm Rebecca. I work at Hamilton Health Sciences, and we've had Epic for a couple years, and I just urge everyone to like temper their expectations a little bit, because there's an avatar, there's this, there's that. But if the nurses are too short-staffed to put the information in, then Epic isn't better, okay? So you still need staffing, you still need education. I went to an avatar of a child with a rash on their abdomen, and it was classified as a pressure injury. So just like before you are using it as a source of truth, and because my organization came to me because I've been tracking the Never events, and they said, can we go from using safety, like the SOR system, safety occurrence report, to just pulling from Epic and slicing and dicing? And I said, absolutely not. And because it is onerous. I personally had a patient who'd had a stroke at home, prolonged time on the floor, 13 pressure injuries I had to add to the avatar, right? Like it's not just easy. It's photos they have my whole heart, and I love photos so much. But just be aware that the nurses still need to be able to identify what is a pressure injury and what isn't. What is the stage of that pressure injury? And they have to have time to be putting these things into the avatar. So it's not just like heaven on earth to have Epic. I'm sorry to burst any bubbles, but just it's more, and I know it's, you know it's not going to solve everything, but just yes, it's going to be an improvement because photos are amazing.
Okay, we have a discussion here. I'm just gonna sit down here for now, just to tackle the conversation.
And apparently Epic, you have to pay extra to have photo capacity in Epic.
Each hospital can choose what version of the system they want. So like Trillium has a really ancient version. Sick Kids has a version that doesn't include wound photos. So it really depends on what they coughed up for.
Yeah, totally, 100%. I understand where you're coming from, but I think when you're coming from the land of paper and going to Epic, it's fascinating and it's better, but it does streamline kind of where the documentation's coming from versus going to different platforms. When you're doing a hybrid and paper, it can get pretty confusing when you're doing consultation, and you kind of have to find the truth to what you're trying to come up with in terms of an adequate, robust, comprehensive treatment plan for your patient.
This pulls a lot on what Chester was saying earlier, right? It's about being able to find and access the data, but also the accuracy of that data. So, you know, there's no right answer, but there's still a lot of challenges.
Yeah, and I think it's important for us to really understand that, you know, any technology can be an enabler of good practice, but it can also be an enabler of inappropriate and bad practices, right? So it's important for us that when we're changing something and we're implementing a new design, a new type of innovation, that people need to understand what the purpose of that tool is, understands the in and outs and the roles and responsibilities, the competency required that allows them to input in appropriate data, because your data is only as good as your documentation. And as what Rebecca has mentioned, like, you know, I personally also use Epic, but I spend significant amount of my time trying to delete the wounds that have been identified as pressure injuries, just because of the fact that they're not pressure injuries. They happen to look like stage 2s, but they're moisture-related lesions or moisture, breakdown. And so I spent significant amount of time, because that will then reflect if that is a hospital-acquired pressure injury into your quality initiatives and quality data.
So just on the topic of, data accessing as well as the integrity of data, I'd love to know what titles are your systems or your clinicians in your hospitals or healthcare sectors using when they're describing pressure injuries? And I know this is a hard one because the terminology has changed a lot in the last couple of years. And if you've been practicing in this environment for, 20 years, you might have seen several different name changes. Josh over here. Oh.
Right here. Thank you. Yeah, the naming thing, I think usually I hear it called a pressure injury, but the one thing as an engineer, one of the things that it's always bugged me a little bit using the term pressure incorrectly in terms of how an engineer would look at it, which is pressure over an area, is force over a given area. If it was really pressure that caused the tissue damage, then you would go diving and you would come out as one giant pressure sore, right? You would come out as a giant pressure injury, but you don't. It's not the pressure, it's not the force over the area, it's actually the change in shape of the tissue that matters. And I think part of the raising awareness of this could help with a good story. And Amit Geffen has been doing some of the best work, I think, on doing the research on what is the etiology of a pressure injury, what is causing the damage to the tissue. He believes it is actually at the cellular level, changes in the cell wall, in the cell membranes that prevent transport in and out of the cell membranes that is the root cause of the damage. So it's actually these cells getting squashed. And making sure, whether we change the name or not, I don't know. I think the story, we need a good story to make sure that as we're explaining how these things happen, how they can be prevented, I think we need a clear understanding of what's happening in the body when these things occur.
Absolutely, right. And the title doesn't capture everything, right? The cause of a pressure injury is not just pressure. It's so deep. Sorry. It's so complex, and there's so many things that go towards a patient having poor skin resilience that puts them at higher risk of pressure injuries, and so many things that go towards that whole getting there. So yeah, it's hard, but I'm quite happy to see that more than 50% of respondents are using pressure injury. But it is kind of going to make data collection hard. If we're talking about doing, prevalence studies, and if you're looking at using EMRs to get your data, this is something that we need to keep in mind, that not everyone's using the same terminology. And you might see multiple terminologies being used within one organization, which makes it hard. Comments, questions? Anybody have a fun story? All right, we will move on to the next one. Does your organization offer education on pressure injury prevention, assessment, or treatment? And this is something that we've kind of pulled on several times today. So I'm excited to see what your answers are and what kind of education you're doing.
we're just hearing here, they can only choose one. I don't know how on the ad end, Caleb, can we edit that live?
Let's see. Okay, hold your horses.
Hey, look at that. Is it working now? No.
Refresh.
No.
Take two.
Didn't press the save button, so I'm not sure how smart this technology is. So we're seeing a lot of people definitely doing it during onboarding and corporate orientation, which I think is fantastic. You know, before clinicians are getting to the bedside. I wonder if you're offering it for onboarding or corporate orientation, is it to all clinicians or is it just to nurses? Why? Right? I know there's a lot of nurses in this room today.
I guess let's do a raise of hands for any organization who's offering corporate orientation for pressure injury education, not inclusive of just nursing. Hands up. So that involves, you know, healthcare aid, PSWs, allied health professionals, physicians, and that pressure injury for corporate orientation caters to all of them. Anybody? So, but two.
Something to work on, guys. If you're thinking about today and what you can maybe take back, this might be one of them that could be easy. Right? When you look at, you know, if you already have something in place, can other clinicians benefit from it? I'll give you a story. I have a chaplain that used to work with me. And she would go in and she would do prayers with the patients and she would raise the bed up so that they were really high during their sessions. And we did some pressure injury prevention teaching with Allied Health and they came and she came back to me and she said, I had no idea. Like she said, you know, when I would finish with my clients, I would leave the head of bed up because their eyes were open and I thought that would be good for them. But we were talking about kind of minimizing that shearing and pressure in the sacral area. And she said that made such a difference on her care. And she would always leave the room. And if she left the head of bed up, she would let the nurses know. Otherwise, she would put it back and help the client get back into the position they were that the nurses set them up in. So something even as simple as that can make quite a big difference because as nurses, I'm sure you are spending as much time as you can with those patients and making sure that you're doing everything for prevention. But if not everybody on your team is in the same frame of mind, how can we make sure that those preventative strategies are being maintained? Anybody else want to comment on that? I'm sorry. I'm not supposed to be doing all the talking.
I think one of the main themes that we were talking throughout the entire day, Caleb, is the importance of interprofessional collaboration and approach. And if we are only educating a specific type or number of clinicians, then everything's just bound to fail, right? Because there's no one person that can make a change. If we really want to make a change to happen, it takes an entire village, it takes an entire team, and it takes an entire world to really make a difference that can be sustainable over time. And so I think it's important for us. There's a lot of homework that we're getting from all of this because we have to kind of keep on reflecting on the common things that we're seeing. And as what you can see, it's not just my problem, it's not just Caleb's problem, it's all of our concerns and gaps. Then we have to just come together and figure out what standardized approach that we can do to ensure that everybody receives the appropriate education that they need to sustain a plan of care that's holistic. Okay.
Thanks, Josh. In terms of your education strategies, I want to know, is there any strategy that's worked really well with an organization? I know we have several different options on here, the ongoing in-person, ongoing virtual. I know a lot of facilities did virtual during COVID. Any learnings or PDS cycles that you guys want to share with us today? Marian?
In my practice, I found it was really helpful to document my recommendation. As an NSWOC, if I documented my recommendation and the rationale for it, I think it made a big difference and it it really increased like compliance with following the care plan and also had a positive impact on healing.
Fantastic, thank you. I think that speaks to the fact that, you know, our documentation can be educational for others who might not understand why we're making those recommendations. So that's a really good point. I like that.
You know, Kayla, I'm a suspect, unfortunately, for dragging all clinicians. So on Epic, there's secure message. And so next thing you know, every time I pull in clinicians like allied health professionals, physio, rehab, OTs, the dietitian, and everybody else and the physicians, they would know what happens next after I tell them a blurb about the patient's wound. And that's the graphic nature of the photos I take for them to understand the gravity of the situation and the need for us to come together to make a plan that will make a huge impact to the client. And sometimes even I feel I become a roadblock for some clients because sometimes clinicians will ask me, oh, Josh, is it okay for the patient because the patient wants to go out, you know, for 2 hours, but I'm concerned that the patient is going to go out there and stay longer periods of time. But again, it goes back to the point that sometimes we're so focused on the wound itself that we're forgetting about the entire person, that there's also that individuality that needs to be addressed. There are other multifaceted needs that they have. And in order for us to give them the appropriate care that they need is to acknowledge that and allow them to also get that buy-in that we need to be part of the entire care planning process.
I just want to add a little bit comment on the in-person or as-needed education. So for me, I just worked more than 1 year. So try to push, not just push, just work with the unit in their huddle, kind of build a habit, for example, Wood Wednesday. So get the interesting cases from that specific unit and share with the staff. I know it's quite time consuming because you go to that unit, you need to block your time there, and you need to wait, accommodate the nurses. Not everyone can go the exact time. We try to get there. So maybe at the end of the day, I can just address 5 to 10 minutes, but I need to be there for about half an hour. But at the end of the year, I found it really works. Because these kind of changes, I found is more effective than just the onboarding one, the general one, because this is really related to their specific patient. What happened to the patient? Not really the pressure happened in the hospital. I had a case, is the lady had a fall and in the bathtub for a few days. And then, of course, the deep tissue injury, but because the patient in the hospital, so we take the picture and we show exactly how the pressure will be affect the patient there. So I told them, if you don't turn your patient, that probably like it will happen to your patient. This is really impressive and help the nurses by, oh yes, we need to turn the patient. Yeah.
I like that, that's great.
So we're from Mackenzie Health here, and we just actually, we're about to, well, actually, we've already started to launch our wound care champion program at Mackenzie Health. So definitely we have like onboarding, you know, education on pressure injuries, on like a unit level as well. Our educators are a really great tool and resource for our nurses, but I think what is lacking is that ongoing education. And so we've recruited champions from across our organization at both sites to be that, you know, in that role to champion best practices, looking at, you know, just even like simple reminders like, have you done your Braden scale? And we have Epic there where we can sort of look at, you know, that unit view and look at, you know, which patients are at higher risk of developing pressure injuries, for example. And we also have quarterly or planning quarterly education sessions where our wound care champions can come in for continual education. I think the challenge though is that maybe other organizations can share, you know, if you have something similar, is that the ongoing, like the sustainability with like a lot of nursing turnover and looking at like sustainability of the champion program. Might not necessarily be wound care or like pressure injury prevention, but like any type of champion program, how do you sustain that program? I think that's something that we will need to evaluate.
So first and foremost, what we had done with our champions program was we went onto the units, and you have to sort of do a road show right? And we asked them to put a small excerpt and give us a little bit of why they're interested in wound care. And we've had the program in since, like I joined in 2018, we've had the program since. This last year was the best year, I tell you. We have because we had done this roadshow, people who were interested joined the program. So even if they're moving from different units, like I know somebody who's gone from the bedside to an OR nursing, she still comes to the Champions program. And she was very pivotal in implementing the Monroe scale in the OR, right? So you have your representation. They have to be interested. That is the first thing. We give them the designated time for education. We're giving them a certificate at the end. It's nothing big. It's nothing. We also have requested the units to sort of give them a little bit more time to share their experiences and be the leaders there, be the teachers there on the units, especially during huddle time. So on certain units, we had to sort of incorporate ourselves, where we went with them and then they were presenting. We just kind of stood there for support. We needed to do that for a little bit, and then we kind of backed off and they continued from there. So you have to sort of make sure that you have interested parties. The other thing is, you're starting the Champions program, don't limit it to nurses only. And you know, I'll tell you, this is the funniest. When we bought a lot of beds from Baxter, and when the beds were being, Baxter came in for education for the beds, I would go in on the unit to see who was interested. And that's where I pulled the OTs and the PTs who were interested. We actually have a dietitian. There are not too many. We have a dietitian. We have 2 PSWs. We have 3 PTs and 1 OT on our wound care champion team. Amongst a group of 50 people, I understand they're limited, but they're there. Why? Because I did not think of the chaplain. The pharmacist wanted to join, but I mean, I think her manager was questioning what she was doing there. So, I mean, you have to, right? So you have to go look for the people who are interested. The effort, I know it's sad but true, you have to be the driving force behind it. If you want good champions, you have to show to them that you're willing to work on them. And if you're willing to put in the time, trust me, they will put in the time too. I mean, we have gotten, this is the first year we've really gotten a good group of champions. Everybody shows up. Those who don't show up are saying, okay, I'm sorry, I had a night shift. I couldn't get it changed. But do you have recordings? Can you send me the slides? Can you talk me through it? I said, I can't talk you an 8-hour day back, right? Come on, give me that much. But you have to be able to give them what they want. And of course, if you're able to get them to sort of do a little bit of a little story as to why they are interested in wound care. And you'll be surprised what they're learning, what you will pick up. And then you can use the stories again. Our champions this year have come up with posters. They are doing, they took away work from us because we were updating our website. And there was one of these girls who said, I'm very good at this. I'll update everything for you. And the sad part is she updated, we haven't had time to look at it, right? Yeah, what are you going to do, right? We are only 3 of us. So, but bottom line is, if you have shown interest, if you get a good group of people, they will come to it and they will be interested in it.
I love that. Thank you so much. All right, so we just have time for one more question before we wrap up for our closing remarks. And this is about incident reporting. We've kind of touched on this a couple times today about which incidents are being reported. So I want to know, in your organizations, are you doing incident reports for pressure injuries? And if so, which types of pressure injuries are being reported? If someone in the room has said that they're not reporting the mucosal membrane pressure injuries, is that because you're not seeing them in your practice? Okay, yes, fantastic. Yeah. Yeah, no, for sure. I think that's the big one with the incident reports is what kind of wound is it? And we talk a lot about, stage 1 and 2 wounds versus moisture associated wounds or other etiologies. Does anybody want to comment on initiatives when it comes to incident reporting that's worked well for their staff?
Has reporting incidents regarding pressure injuries build fear or it build shared accountability?
I think reporting any incident is not about taking a blame. It's like more room to work on it. So it's never happened. So I feel like if you see something, if you report it, it's not like we did something wrong. It's like we are taking action to it not ever happen after it happened that to the patient. So I think our hospital, we reported anything new happened, we put in the search report. That's a global thing, go to the manager and also from the team lead and the doctors, so and OTPT, so we can know what happened to the patient and then we can take proactive action for the next one so it doesn't happen to the next patient. So that's the way we do it.
I really like that your incident reports are going to the interprofessional team. I think that's quite great. I know in our organization, they're more going up to the quality and risk team. So it's nice that it's kind of pinging the professionals that might need to do something about the problem. I like that.
I think my colleague Carol has something to say. I love my colleagues.
Thank you, Josh. Yeah, so we do incident reports for stage 2 and above. And I must say that our incident reports in the last year have increased a lot. So when you talk about being punitive, our team know it's about quality improvement and using that data for patient safety. So it has improved, not because every incident is a pressure injury, but almost every skin injury is reported. So kudos to our team, and actually kudos to the Linters PASI or Massive, I'm going to say that, because I joined their program when they already had developed many programs in education, incident reporting, and pressure injury initiatives. So once the incident is reported, it goes into a repertoire where our leaders are there, the director, medical director, and all staff members, included all the advanced practice educators. Then there is an investigation that would happen. So at the safety huddle, so there's safety huddles every morning for about 5 to 15 minutes or 10 minutes. And that is discussed there. Once that is identified, then there is like a post-huddle discussion to see, what really happened. We have the interprofessional team get together with myself, sometimes the doctor, and we figure out a plan. We then go in and investigate to see, really, is this a stage 3 pressure injury? We just wanted to validate. Once we have validated the incident to say, yes, it is a stage 3, this is now discussed with the manager, who will make a call or discuss it with her advanced practice, like Heather, who's in the back, to say if it is if it's a serious safety event, so an SSE. Then there's a call made, we get together, we talk about that, and what we're looking for, if there's any variances from our practice. Like, did we do the skin checks? Is there documentation of that? So it could be, and I know we spoke a lot today about documentation, the importance of that. So the nurse may have done everything, for example, and I'm not trying to single out the nurses, but they may have done all their assessment, but if it wasn't documented, then we have no evidence, right? So we look into that as well. And then from there, we look to see if, again, if we had stray away from, normal practice. And if we did, then it could become, sorry about that, a serious safety event. And from that, we look at things that we could done differently, things we have to improve on. And one thing I didn't mention is that the patient is always notified about this. They're always part of the discussion. And once we have decided whether or not it's a serious safety event, the manager goes and discusses with the patient to say this is where we're going to move forward with, or the team. It doesn't always be the manager, but it could just be the team. We get together at the bedside and discuss with the patient that this is what happened, this is what we thought may have happened, and this is how we're going to move forward. Sometimes it could be very upsetting. And as Joshua had mentioned earlier, we do use photograph. They're so impactful. So for those patients who probably didn't want to turn because, their pain hasn't been managed appropriately, or they get in a lot of spasm when they turn, it's so impactful because they say, oh my goodness, right? Because you could imagine that patient could have been in a hot plate, but they didn't know something was happening. So when they see that photo, it tells them, yes, this is real. So that's how we do it. And again, it's never punitive. Our nurses are on top of it. Again, they report almost everything. So it's really a good culture of making sure the issues and concerns are brought forward. And I think our organization really set us up well for this, especially at our safety huddles. So again, kudos to the team who have done so much in pressure injury prevention, and to everyone here today.
Thanks, Carol. And I can be a witness to what Carol has mentioned, because a culture like that, I've never been in an organization where everybody flags for everything. Even at the middle of the night nurses will message me at night, Josh, the patient's developing a stage 2, can you please follow up? So I like to reinforce that kind of behavior, because you need to escalate care before it gets worse. And so kudos to the team at TRI and UHN for making that kind of culture apparent and making it more of a team approach process.
Hi, everyone. Appreciate hearing everything. It's so interesting. The how that you're describing, is that provincially mandated that each of the corporations in acute care, long-term care, is that a provincial mandate that the huddles take place, the serious incidents are documented? No, it's not. So it's, yeah. Okay. I have a second question. Under the medical device related injuries, is there a space where you document in the incident what device created the injury? Is that something that would be picked up on data?
Usually, yeah.
It's free text.
Food for thought.
Yes, there is. And also there's a pretext that you can document it. Yes. Yes.
And I think part of that exploration process is the CNS or the advanced practice nurse who comes in to do the comprehensive assessment to confirm whether the culprit behind it is the appropriate type of device.
All right. So we are nearing the end of our show today. Sure.
Thanks for coming and joining our show.
I did a little dance up here earlier.
Ladies and gentlemen thing too. Yeah.
It's a show. So as we kind of close up for today, I just wanted to say a thank you, first of all, to all of our speakers. Today's been a momentous day, really. Our speakers and you all have really highlighted the cost of pressure injuries, the challenges that we're facing in preventing pressure injuries, but also caring for pressure injuries, as well as their impact across the continuum of care. And we also touched on several solutions. So in terms of kind of some of the gaps that we heard across the board today, we heard a lot about nursing shortages, nursing retention. We heard about the lack of accountability for pressure injuries.
Lack of a standard approach or framework across the nation.
Yeah, definitely no jurisdictional or federal strategies, lack of equipment,
lack of the increased need to act immediately when a pressure injury risk has been identified.
and then, of course, we've talked a lot about this afternoon as about the data part of it, not being able to find patients who are at risk for pressure injuries, not being able to find where it's documented, what's documented, inaccuracy of documentation, a rash versus a pressure injury. These are all kind of challenges that we face day to day.
And so I think just you guys coming in here for today and staying here all the way for like almost 8 hours or more shows a lot of interest and a great deal of enthusiasm to do something about the gaps that we have identified. So I think what we will do as part of a CPIAP team is actually we're going to take back all of these identified challenges, the strategies that you have proposed to us, and I do hope that what we have here today, the attendees that came in here today, becomes a somewhat kind of community of practice catered towards making a difference in pressure injury prevention and management.
Now, when we talk about things that you guys can go back and do, we've talked about a lot of solutions today, and some of them are small and some of them are big. We've heard about the need from learning from our interprofessional partners. Dr. Gavison was talking about how the patients and the clients were asking for wound teams and teams that had that interdisciplinary approach. So it's not just, us and the guidelines that are saying it, the clients are saying it as well. And we need to be able to treat the cause of those pressure injuries, not just the symptoms, which often are the pressure injuries themselves. Other things that we've looked at for possible solutions include technology, and I know we talked about Epic a lot, not to name names, but also other digital tools that can be of assistance. Things like nursing ratios, looking at that to support pressure injury prevention, as well as the integrity of data.
So there was a work by James Senrati earlier about the modeling and the tool that he has developed that allows us to really see the gravity of the workload and issues and ensuring either that could be an enabler for promoting practices or that could be also just an enabler for promoting, increasing the number of pressure injuries. So also, I was thinking about it when we're talking about the different terminologies for pressure injuries, from pressure sore, bed sore, decubitus ulcer, possibly the role of AI may come into play, like, as leveraging technology, trying to find a way to capture all of these key themes and keywords that then allows us to streamline the approach to identify the types of wounds appropriately.
I think there's so many options when we talk about pressure injuries, strategies. And I think we've heard it again and again today that really we do need those big solutions as well, policy solutions. We need guidelines that are going to be usable for all users, including the neonatal population. And we need to make sure that we're supporting those transitions of care from critical care all the way to home care. We should have a smooth transition where at every point we're supporting pressure injury prevention.
I like how Dr. Ho mentioned that one of the great things that we're doing in Canada is we're creating all of these standards, right? But where are these standards? How are we measuring those standards if people are implementing them? How are we sustaining them? At the same time, we are actually being redundant with the work that has been done, the great work that are being done elsewhere. How can we come together and collaborate so that we have a standardized approach on how we can address pressure injuries?
I think it's clear that there's an opportunity to develop a national framework for pressure injury strategy, along with all you stakeholders, because everybody in here brings a voice, as well as our industry partners. Everyone comes from a different perspective. That's really important. And when we're talking about building our standards and our policies, we really need to hear from everyone. CPIAP's really excited to take what we've discussed today and what we've learned today back to our board to really help mold our strategic plans as well as our future initiatives. But before we go, we want to give a big round of thanks to everyone who made this day possible. So to start with, we have our board of directors, which are from across Canada. We also have all of our amazing speakers. Troy's realizing that I'm not going in order. I'm sorry.
So we want to thank Pam Yulee, Dr. Lee Chapman, Dr. Chester Ho, Dr. Sharon Gabison, Dr. Kevin Wu, James Senrati, Luz Odriel, and Dr. Catherine Craven, and my co-host today for this show,
And for you.
Caleb Below.
And then in terms of our sponsors, we couldn't have done this day without you. So we want to give a special round of applause for Baxter, Coloplast, Medline, Mölnlycke, Profuse, Smith & Nephew, Sarah Ergo Medical, and Sensor. You guys were very important in making this day possible, and we're so happy that you were able to join us for our first ever pressure injury summit.
The first and never going to be the last.
And then we also want to thank our partners in today's event. So we couldn't have done this without the University Health Network team and Toronto Rehab Institute.
Yep. So I want to thank Gabby Gallia today. And unfortunately, she couldn't make it today. She sends her regrets. She has recently lost somebody that's close to her. So a heartfelt condolences to her and her family. But she was here in spirit, and she was actually watching us online. I also want to thank Marcel Abdouli, right over there, for showing us the place here at TRIUC that allowed us to have a venue today. Carol McIntosh for linking us with Dr. Craven and Luz as well. And Delia Medeiros, Kyla Kumar, Dennis Mendoza, and the environmental support team that allows us to have, although the room is small, they made it as spacious as possible for us. And Matt Proctor and the audiovisual team that minimally, we didn't really have a lot of glitches today, that it was smooth process along the way. We're tackling this both in person and also online. So that was smooth sailing from there. Thanks to your team.
And then, of course, we couldn't have done this without the support of NSWOC. Our planning team, Kathy, Troy, and Jonathan could not have done this without you guys. Thank you. And then, of course, thank you to everyone who came today, both virtually and in person. Your feedback has been so important to us, and your presence here and your support for both CPAP, but also pressure injury prevention and treatment. So thank you to you guys and for everything that you do for your clients, either upstream or downstream. As Dr. Ho said earlier today, pressure injuries are a silent pandemic in the Canadian healthcare system, but they shouldn't be. We need people like you shouting about them from the rooftops. Nobody should be whispering about pressure injuries. Everybody needs to know about them, and everyone involved in healthcare and client care should be talking about pressure injuries, because their prevention can save millions of dollars in healthcare funds, can significantly improve the lives of your patients as well as their families and friends. I hope everybody today leaves motivated to make changes in their sectors, from small patient level changes to large policy changes. Pressure injury prevention cannot happen overnight. We know that. We need a nation united in pressure injury prevention, management, and policy in order to make the biggest impact. And with that, thank you, everybody.
And to usher you home to your special areas, the last carrot and stick that we'll give you today, actually the carrot, is there's coffee and also sweets at the back room. Please feel free to grab some along the way as you take your journey home. Thank you very
A
much.
snack for the road, everyone. Yes.
Sorry, just one more thing too. If you have not already, please check in at the very front. We're going to be sending out certificates of attendance, so we need to record that you were here. Thank you so much, everyone.
Thank you, everyone. Bye.